so everybody wants to be on it. We've developed some new data on individualizing factor therapy in patients. So like something like PK that we do for factor therapy, but PK is a very laborious process, as you know. Pharmacokinetics in hemophilia patients requires a lots and lots of blood draw. So we thought maybe we can ease that by using our technology. So I'll show you data on that. And then, of course, everybody's talking about non-factor therapies, which are coming in the market or in the research. So we want to see how our, assay function with that, and then some future studies and plans. So those are objectives, lots of things to discuss. So let's dive into the point of care technology for coagulation disorders. So point of care basically means something that you can do at the point of care of the patient. So it's diagnostics that patients can either take home or they can do in the hospital, but it is quick. And the idea was to shift focus from very high cost specialized care that is available in coagulation labs and take it to the patients to prevent personalized healthcare. Now, these are the examples that you can see below: pregnancy, diabetes, glucometer is an example of that. But the most famous one is the pregnancy, right? You're used to the pregnancy test that is at home. That's a point of care test for detection of pregnancy. And then other new one is the COVID test, which we all are doing nowadays. The COVID test is a point of care test at home. It's testing the antigen. And then diabetes is testing your blood glucose levels. So this was our inspiration, that if somebody with diabetes can measure their blood glucose, why can't a person with hemophilia measure their own factor level at home? So that's where the whole idea came from, and whole discussion is. So let's talk about that. So as I said, coagulation monitoring is difficult. It's needed. It's difficult. It's needed because of a variety of reasons. Obviously, you want to detect bleeding issues in patients, and you also want to monitor anticoagulation therapy at times. And most of these patients are either ill or in the ICU or with trauma. That's where the coagulation monitoring mainly happens. The conventional tests that we have, the PT and the PTT, are available everywhere now. They were not initially, but now they're available everywhere. However, they're still costly, labor intensive, so you need a coagulation lab to do them. And more importantly, they only provide a snapshot. So at that time point, what is your PTT will only that information you will get. There is no feedback mechanism of there is no contribution of platelets, for example, in the PT or PTT. There are lots of fallacies of PT and PTT. We can go a whole 1 hour lecture on that. But those are the tests that are available to us everywhere, right? And then there are some point of care tests, like the CoaguCheck. Now, CoaguCheck is a commercially available coagulation assay, but it is only used for a very specific patient population. It is not used for example, for hemophilia patient. It is only meant for monitoring of coumadin. That's how it was developed. It's a very crude assessment of the coagulation process, but it does its job. It also does not provide the whole picture, the whole coagulation picture, if you will, the whole blood assay. So it's a very specific test, but that's an example. If you go in the literature now, you will see lots of these assays in development, because everybody wants to develop a whole blood assay that can give you the complete picture. So that's become the whole holy grail. Because as we know, the whole blood has lots of proteins besides the factors. So the contribution of each and every protein in the blood towards the coagulation process becomes a great thing to measure, right? Because then you can know whether you have a bleeding risk that is high, the bleeding risk that is low, or what is going on. So if you look at the literature, you will see all these new technologies, sensor technologies, and different detection methods, either through optical measurement or light measurement. And everybody has their own sort of, limitation. So our assay is kind of similar to these technologies, in the sense that it is specific to a particular way of measurement. But before we even talk about that, let's talk about point of care in hemophilia. Why is it needed and where we are, right? So hemophilia is actually a poster child for patient-centered care, what we call. So everything revolves around the patient, right? We tailor therapy to the patient so that they can monitor their bleeding patterns according to what their factor levels would be. So that's what the traditional PK does in patients, right? But most of the point of care testing in hemophilia is actually point of clinic. It's not really point of care. That means a lot of care in hemophilia actually happens at home, right? They do all their factor. Most patients are able to do factor at home. They don't have to come to the clinic. So then that's where they need to know what their factor level are if the need arises. So it's really point of care right now, not point of patient, point of care as in the patient's hand. And then one of the examples is this population guided, population individualized PK, like Watts, the Watts Hemo that we have nowadays, right? It's a web-based program. You can input some data, PK data, and then it tells you what the curve of the patient would look like. So that's an example of point of clinic rather than point of care. The only place where the real point of care was used in hemophilia was patients with inhibitors who were in the early days, at least, when the bypassing agents factor 7, so recombinant factor 7A and FIBA or APCC was used in the beginning for hemophilia with inhibitors. People tried these viscoelastic assays, which are whole blood assays. They're point of care. And I'm talking about, ROTAM or TEG. And a lot of you may already know what ROTAM or TEG is. So these are true global assessments, hemostatic assessment of the patient's coagulation as it happens, as the blood clot forms. And the curves kind of look like this, and the machine looks like this. I'm sure you have seen this in any one of the centers that you work in. The problem with this is that it is pretty bulky. It's big. You cannot obviously take it to patient's home. That's not possible. And there are other sort of nuances to this that it has to be a very still environment. There should be no vibration. It requires trained personnel. So a special coag lab person is needed to run these assays. Otherwise, there will be variability, there will be problems. So patients cannot really run this. So it's not true point of care from that perspective, but it is like point of clinic. We can have it in the clinic. And as I said, there are some other issues with it that are not the discussion topics today. But given the background, that's where we started wondering whether we can introduce a new method of point of care. So I work at the university, and there's a biomedical engineering department here, and there are scientists or PhDs who are brilliant. I work with a lot of them, and we take problems to them. This is a big problem for us. We can't measure factor. And that brought up the whole discussion of how you can actually do this. And they were working with dielectric spectroscopy on different other fluids. And then we tried it in blood. And that's where this whole assay came about. But I'm not the inventor of it. My name is on the patent, but there are other inventors of this original technology. So dielectric spectroscopy is actually a very well-established method. It's not new. It's a measurement of permittivity of any material. So you can take any material and you can see what it emits, what electrical signals it emits. You can plot it at different frequencies. And the physiologic properties of blood in real time is what it measures. And you take any tissue, DNA, cell, protein, lipids, at different dispersions of the electricity at different frequencies, they'll have a different pattern. And so that's what permittivity is, for dielectric spectroscopy is, the DS as we call it. So DS, when applied to blood coagulation, becomes dielectric coagulometry. So we call it dielectric coagulometry. And we wanted to miniaturize it so that it can be fit into like a small cell phone, a mobile phone, just like a glucometer. So that miniaturized version is what the assay was finally envisioned. So this is what we envisioned, a fully electrical technique, non-invasive in the sense that it is, you need blood, but beyond that, it's non-invasive, it's label free. The DS function, the dielectric spectroscopy function, is integrated into the microfluidics. If you want to miniaturize it, you need small channels with very small amount of blood. So we use like less than 10 microliters of blood. So it's like a really, really small amount. Just a drop is enough. And and it's portable, of course. It's portable. It's point of care because it can be taken anywhere. That was the whole idea of development of it. So how does dielectric spectroscopy work? As I said, there's a dispersion region in every megahertz frequency. Now it actually happens because there are red blood cells in the blood. If there were no red blood cells, the polarization that the electricity needs to measure would not happen. So you may know this, but when blood coagulates, the very first thing that happens is actually not the platelets. It's actually red blood cells aggregating with each other. And the shape change happens in red blood cells. That's what the dielectric spectroscopy picks up first. So these are the curves that are showing that. If you take plasma alone, this polarization won't be seen. So the whole blood, you can see spectroscopy is different than blood plasma, which does not have red blood cells. And our chamber inside that machine looks like this. It has an inlet and an outlet. So it's microfluidic. It's a very small chamber. So it's barely taking a drop of blood in this, which it flows through here. Now, it's not a dynamic assay. It's a static blood assay. So that means the blood coagulates in this chamber. It is sealed off so that it doesn't dehydrate. And then it's measured with a transmitter and a receiver, like a radio or whatever. So that's the whole function of this whole assay. So when you take blood, as it is coagulating, as it is going, so you have to add calcium chloride, obviously, otherwise the blood will not coagulate. So if you take no calcium chloride, then it will be just like a straight line like this. But if you put calcium chloride in it, it creates a curve like this. So there's a time it takes to form a blood clot, and then there's a time it goes beyond that. So this time we measure is called the T peak at room temperature. And this is the very first initial publication that we had with this method. So as I said, on whole blood, it is sensitive to aggregation of red blood cells. And it forms two characteristic processes. Now, initially, when we designed this, there were only two measurement variables that we were doing. So this first one is the T peak. As you can see, these are two different curves of two different patients. The time it takes to peak is different between the two. And then after the T peak has come down, the difference in permittivity that happens after the initial rise, we call it delta epsilon max, and it has a specific sort of function to it. So like T peak, like delta epsilon max, now we have total of 5 different parameters. Just like the ROTEM has lots of different ways that there's a CT parameter, there's a max parameter that measures the width of the curve. Similarly, we have different parameters in this, but this is point of care. This is at the side of the patient. That's what we are envisioning, right? So the first thing we did was we wanted to measure it correlated with ROTEM, right? Because ROTEM is the gold standard in the point of care right now. So we did exactly what ROTEM assays would do. So this is a ROTEM assay, if you are, or a TEG assay that you are familiar with. The clotting time is a CT parameter. If it's untreated, that's what the blue curve looks like. If you put antithrombin, so we put, I think we put Aplicación to this. So it's an antithrombin agent, and it flattens like this. And then you add thrombin back, and then it normalizes. So we did that in our patients population and with clot chip, and we were able to show that untreated was a curve like this. With antithrombin, the curve kind of prolonged quite a bit. There was no T peak at all because there was so much of antithrombin in it. And then thrombin kind of brought it back towards the left-hand side, as you can see. So it correlated well. We did an R parameter, which is pretty near perfect correlation with the ROTEM CT parameter. So we were happy with that. And then we wanted to see whether the delta epsilon max, it correlates with your, with our, what does it measure? So we were able to inhibit with cytochalasin, which is basically a platelet functional inhibitor. So with different concentrations of site D, we were able to show a difference in delta epsilon max, which correlated very well to the MCF parameter in rotem. So it was, so if you the maximal clot firmness in rotem actually measures how well your platelets are functioning. So whether you have a strong clot or not from the platelets, that's what it measures. So we were able to do the same thing in the clot chip with this, and there was a pretty good correlation to that as well, right? So this is the corresponding rotem assay that you can see with different doses of site D. So that was good. And then we wanted to see whether it was able to pick up coagulation defects, right? So before that, we had to do some healthy volunteers. So at this time in 2018, we had a few samples. Now we have more hundreds of healthy volunteers that we have data on, which has not changed much. But this is from the publication. So the T-peak in healthy volunteers was measured, was documented. Just like any assay needs a normal range, we were able to figure out what the normal range would be for healthy people. And then we compared it to a variety of coagulation disorders. As you can see here, hemophilia, Willebrand's disease, hemophilia B, back to a 12 deficiency. So you can see the curves are very different in each of these, like they are prolonged. Obviously, the T-peak in a bleeding disorder shifts to the right. That's what happens. The parameter is prolonged in these patients. So we were able to show a very nice difference between healthy and unhealthy or coagulopathy patients in general. So we wanted to kind of see whether it was able to pick it up. So it was sensitive. Then we wanted to see whether it picked up platelet inhibition. Now we did not do this in platelet function defects. Subsequently, we have data on that in patients. But this data that was published was from patients who were healthy volunteers, and then we artificially added aspirin to their blood samples in different concentrations. And we showed that as the concentration of aspirin changes, the delta epsilon max changes, and which is very well correlated with the aggregation. So we did aggregation on these after adding aspirin, light transmission aggregometry, LTA, on all of these patients, and compared that to our parameter, delta epsilon max, and showed a pretty good correlation between the two. And we had about 30 samples. Each concentration was statistically different from the other as it related to delta epsilon max. So this was pretty encouraging data that it was able to detect both of these things. Obviously, with this data, we wanted to see whether now we can make a difference for patients. So we took that to hemophilia patients. So these are the few initial studies that we did in the hemophilia population after we had data in the lab with manipulating a lot of things that I just showed you. So we wanted to see whether it can detect as well as monitor therapy. So by now you know what the T-peak looks like, right? So these are three different patients with three different curves. So the blue curve is the normal curve, and the T-peak is measured in time here. So we give a numeric value to the T-peak in the instrument, so it comes up as whatever minutes, like it will come up as 4 minutes or number of seconds. And then a hemophilia patient, as you can see, this is without inhibitors. You see the curve is directly shifted to the right, and the T-peak is between 10 and 20 minutes. So this is around 18 minutes. And then look at this. If you have an inhibitor with hemophilia, and this was before ME was in the market. So this was just about the time when ME was being used in patients. The inhibitor curve looks very different from somebody without an inhibitor. So the T-peak is way prolonged. And this tells us that the bleeding tendency of this patient is very different. And I don't have to tell you this. You know that already. Patients with inhibitors bleed quite a bit. They don't bleed just like the hemophilia patients, even at rest, right? So this was able to differentiate it very well. We got so good at it that by T-peak, I could make out if somebody had inhibitor or not. So it was elevated in hemophilia and further prolonged in the presence of an inhibitor. And this was very different, statistically significant between the three groups that I just showed you. And then we gave factor to these patients. So the patients without inhibitors got regular factor, factor 8 or 9. And then the patients with inhibitors got either Novo 7 or FIBA, because you can't give them factor therapy. It will not work. So these are different colors, as you can see, with different time points and different T peaks. Let me walk you through that. So the blue and the green are without inhibitors, and then the black and the red are with inhibitors. So obviously the curve in the red is way prolonged because it's with inhibitor. Without inhibitor is the blue curve. So it is still prolonged in this patient. However, when you give, without inhibitor is the green curve. So when you give factor to this person without inhibitors, so this is the pre, it becomes the blue curve. So it goes back into the normal range very nicely right here. And without inhibitors, it starts off here, very prolonged T peak between 30 and 40 minutes. And then when you give the factor, it goes back to the black curve. So you can see very nicely, we were able to show that the curves normalized, the T peak normalized, came back into the normal range once they got factor. So it was sensitive to coagulation factor therapy. More further than that, we were able to show that patients who were without inhibitors were different than patients who were with inhibitors. Even further than that, we were able to show that once you had an inhibitor, if you were tolerized with inhibitors, you were in the range for come back here. And if you're non-tolerized, then you were in a higher range, which kind of again makes sense. Now, this patient, as you can see, is way prolonged TP, right? This is in seconds, this is not in minutes, of course. But this patient bleeds a lot more than these patients do, even at baseline. So we were able to pick up coagulability, if you will, if that's a word, in whole blood from these patients. And all of them came back in the normal range once we gave them factor or bypassing agent. And this is the normal population, as you can see. So we were able to show very good sensitivity to factor as well as detection of hemophilia. Then we wanted to test, since ME came to the market, we wanted to test patients on ME with our assay, obviously. Initially, as you will remember, only patients with inhibitors were getting emicizumab. So that was our first data in that. So we wanted to see, first of all, whether the assay was able to pick up ME or not. That was the basic intention. We didn't want to see whether we're able to monitor it with with this the assay or not. We just wanted to see whether it was different. So we did one patient, we gave them ME, and they were starting anyway for clinical purposes. We did a pre-sample, which is in blue. So their curve, obviously this was a patient with inhibitor, so their curve was very prolonged, as you can see, between 30 and 40 minutes, right, if you remember. Then at 2 hours, this curve started shifting to the left, 2 hours after ME. And then in 1 week, it became pretty much in the normal range. And then at 8 weeks, again, it was still in the normal range. So, but it's still further down, but it's still. And then at this time, it kind of stayed there. So we showed a decrease in the T peak as expected in response to ME for patients who have hemophilia with inhibitors. And then with different patients, we kind of were able to show the same thing. It started at different TP, but they all came down in the normal range within a week, and it kind of stayed there, which is what we see with ME. Nothing much happens after they achieve a normal level, and then they kind of have pretty stable kinetics. And we were able to show that along with this assay. However, beyond this, it is not going to change much. So we'll talk about whether it is needed for monitoring. But if something happens to ME, like ME antibodies, then this will again go back to the higher range. So it is able to pick up that pretty easily. What about without inhibitors? So then further than that, ME was available for patients without inhibitors as well. And kind of similar thing we showed. Now this is a very crowded curve. So let me show you. So the pre is without inhibitors. So the T peak is not between 20 and 30 minutes, right? So that was what you were saying before. Now it is between 10 and 15 minutes. So it is a shorter T peak, but still with hemophilia. After then 4 hours, just start going towards the left. So that is the T peak at 4 hours. Now, if you remember, we also give factor to patients who start on ME at least the first 2 weeks, right? We still give factor. So we got this patient in the clinic, we got the pre-sample, and then at 4 hours, before we gave the factor to this patient, we got the 4-hour sample. And then after we gave the factor, we took another sample. You can see the curve further goes towards the left. So it was able to pick up even further in addition to ME with factor 8. And then at 1 week, the patient came back, and then that's the black curve. So it is now not as shortened as the one with factor 8, but it has come back, it's right there where it should be. And then with factor 8 on top of it, because in a week, again gave factor, again took the blood sample, and then it further shortened into this light color as well. So we saw not only a decrease in T-peak to ME therapy, but we also showed that if you add factor 8 to these people, it further decreases T-peak compared to ME alone. So it was sensitive enough that it was able to pick up further coagulation correction, if you will, which was pretty remarkable for us at that time, because we did not expect this. And then we wanted to play around a bit with the patient samples a little bit. When I say play around, I mean, we wanted to see how sensitive was the assay with ex vivo spiking. So if you added different concentrations of ME, different concentrations of factor, what happened to the assay? So that's what we did. So this is the first one right here. So these are two different groups of patients without and with inhibitors. So the circles are without inhibitors. Obviously, the clot chip T-peak is lower. It's still higher than normal, but it is lower than somebody with inhibitors, right? So you can figure out right away now who has inhibitors, who does not, right? By now. And then we added in from their blood. Now this is not in the patient, it's external. So we took their blood, we added ex vivo ME to the blood sample in the test tube in different concentrations. And we showed that ex vivo spiking with ME in blood from patients with hemophilia with and without inhibitors, right? Both of these patients showed a concentration dependent decrease. So it went from 0.3 to 1 to 30. It kept going down up to a certain range at the lowest level of the normal as well. So it was, the T-peak parameter was sensitive enough to do that. But once it reached there, it would stay the same. It didn't move after a certain point. But at least it was able to pick up different concentrations. And then we added factor 8 to the samples as well, right? Because we wanted to see further addition of factor 8. Did it make a difference? And yes, it did. So these are two different concentrations of ME. This is 1 microgram per ml. This is 30 microgram per ml. So you can see at baseline itself, the T-peak is very shortened. Obviously, with ME on board, it is pretty much in the normal range by 1 week. And then you add 60 IU per DL of factor, 80 IU per DL of factor, it further keeps going down, right? So these are samples that added factor, further addition of factor 8, further decrease the T-peak, but it stopped at certain points. And then we did something very interesting. We added factor 9 to factor 8 deficient patients. Now, if you remember, subsequently data has come out that factor 9 is a driver of the reaction that happens when ME is given to somebody, because it's a monoclonal antibody that combines the 9 and 10 along with 8. So 9 is really the driver of this equation. So when we added factor 9 to this mix, it actually decreased the T-peak to the level that we have not seen before. So that means it was true. You can actually give factor 9 to somebody with inhibitors, ME, and it will really work if you were in a bind for. Of course, we haven't done this in patients. This is just in the test tube, but it kind of proved our theory. So this was addition of 8 or 9. And then we also obviously wanted to see with FIBA and NOVO7 whether at different concentrations, whether it made a difference to T-peak, and yes, it did. This is 1 concentration of ME only, and addition of FIBA further decreased, and addition of NOVO7 or factor 7 also decreased, but not to the same degree as FIBA. Now, if you remember, a lot of FIBA is problematic in patients with ME, and we were able to pick that up in our assay because the T-peak was so shortened that there could be problem in terms of thrombosis for these patients. So we were able to show the difference between 7 and FIBA, which was kind of remarkable as well, right? We correlated all of these to thrombin generation. So that's the other assay that we didn't talk about today. Thrombin generation is the other, I wouldn't call it point of care, but it is at least a point of the lab assay, if you will, which is, we were able to show the TP parameter was correlating to the endogenous thrombin potential in the TGA assay as well as the peak thrombin. So we were able to show pretty good correlation between the two parameters as it relates to the T peak. So this was good data, obviously, in actual patients with hemophilia that were contributing blood samples to us. But obviously then the question becomes, how do you take this from the lab to the patient's hand, right? That is where we initially started the work with. So the license, as I said, the technology was licensed commercially by the startup company who bought it from the university, and is local here. So it's in Cleveland. They are the ones that branded the ClotChip name, and they raised a lot of money, $9 million in about 3 or 4 years ago. They created a prototype, which was, again, the glucometer was the inspiration. And this is what it looks like. So we have these devices now that, again, they're not commercially available, but we use them on patients now, again, for a lot of more research, and has a sensor or something that goes into the machine. That's where the blood is put. That thing that I showed you, that's where the inlet chamber is right here. And then you put it in the machine and it measures and gives you a numerical value as well as the curve that we just talked about. All of that I showed you shows up on that screen in the patient's hand, so to speak. So what could be the potential clinical use, right, of something like this in hemophilia patients? So we don't currently measure point of care factor levels in anybody, right? Because we don't have the ways to do that. But we do know that one size does not fit all, right? So everybody needs different kind of therapy. That's where the individualized therapy comes from. And we also know that there are not only within, but even between patients, there's a lot of differences in PK, pharmacokinetics of factor therapy. The factor does not really follow the curve that we assume it to follow at all times, at different stress levels, after surgery, after activity, we don't know. And even after tolerization from inhibitors, we know that people sometimes keep having bleeds or not normalize their pharmacokinetics, and it takes time for them to do that. So there are a lot of variations, obviously, that potentially could be a use of a point of care assay like this. And then gene therapy is coming in, and obviously, I'm sure you guys are excited as I am. We have a couple patients on gene therapy trials here. And this unpredictability of factor levels after gene therapy, it's not that constant. It keeps going up and down, sometimes more down than up, but it takes time. So could you use something like this to monitor the levels after gene therapy? Possibly, right? Then somebody can know where I am after gene therapy before doing a activity. And of course, there is utility of non-factor therapies that don't have currently monitoring techniques. We'll talk about that in a minute. But more excited about all of this is the concept that you can actually modulate your own bleeding risk during activities. We come across patients who have different kind of activities for their lifestyle, and they have bleeding issues because we don't know where to keep them sometimes. But we know that a particular trough level equals to bleed-free status. So if you are about 10 or 15%, 95% of the patients, 94%, 97% were bleed-free. That means pretty much everybody will be bleed-free beyond a certain number. But how do you know whether you are around here all at any time point before you were to go for, a sports activity of any kind for a child or for even for an adult doing certain activity? Could you basically divide them into zones, the green, red, yellow zone with different risk levels? But the patient can figure that out themselves at the point of care in their own home. They don't have to come to the clinic for that. They'll know where they are before they pick up that soccer ball and go onto the field. I am okay right now. I don't need to dose. If I'm in the green, maybe I should dose if I'm in yellow And maybe I shouldn't play if I'm in red, right? So that kind of control, that kind of power in patient's hand, possible with someone assay like this. That's where the original inspiration was. So the first summary that I will give you, there's a lot of data. We proved that clot check T-peak is sensitive to coagulation time, and it correlates with CT parameter and totem. I showed you that the delta epsilon max is sensitive to platelet function. It correlates to MCS parameter and rotum. I showed you that it differentiates between normal and coagulopathy blood samples, right? I showed you that T-peak is prolonged in hemophilia. T-peak is further prolonged in hemophilia with inhibitors, right? It can differentiate between the two. And then T-peak is corrected back to the normal range once patient is administered factor or bypassing agent. And lastly, that it is sensitive to the presence of ME in blood. Now, I'm not saying that you need it to monitor ME, but at least it's sensitive. It can pick it up pretty fairly well. So that's the first summary. And then the last few things that I want to talk about is trying to put that vision of can you monitor factor at home? Can you monitor your own activities? You know, the red zone and yellow zone I talked about. But for that to happen, you need to have pharmacokinetics with clot chip. Can you actually replace the traditional pharmacokinetics with a point of care assay like clot chip? That's where the rubber meets the road, right? As they say. So we did a study with funding from Exotech. And this is data on one of the patients on the study, hemophilia A patient on an extended half-life factor, twice a week. He was tested. So we did a washout, just like a traditional assay would. And then we took blood samples, right? Because we wanted to correlate a chromogenic factor level to the clot chip. So we took blood samples immediately prior to the infusion of the extended half-life, and then at 30 minutes, 1 hour, 4 hours, 8 hours, 12 hours, 24 hours, 48, 72, 96. The patient actually stayed overnight for this and then came back daily to the HTC to get the blood samples drawn at these time points. And then since this extended half-life was twice a week, the second infusion was given, right, in that same week, immediately after the 96 hours, right, because it was time for the patient to get another one. And then blood samples again drawn daily, 24 hours, 48 hours after the second infusion. So we wanted to see how in real life this would look like. So at each time point, now this is showing finger prick, but we actually did venous samples, not finger prick. So this is another study that we are doing with finger pricks, and this is the device that we use in the clinic. At each time point, blood was drawn from the patient's vein into a sterile syringe, and then one drop was placed in the clot chip, and then the rest was, sent for chromogenic assay measurement. So what did it look like? All right. So this is the curve. So obviously, the blue is your T-peak, and the red is your chromogenic level. Now remember, when your factor is low, your T-peak is high, and when your factor is high, your T-peak is low, right? So they should look like a mirror image of each other. So they do look like a mirror image of each other, as you can see. As your factor goes down, your T-peak goes up, right? That's the biggest difference. And then as you give the second dose, the factor levels goes up, the T-peak comes down, and then so on and so forth. So it is exactly a mirror image of each other, and that's what we wanted to see. So this is in numerical values, the same thing that we just showed you. It kind of at different time points, at different T-peak levels, at different factor levels after different doses. So we were able to show this very nicely, and this is not published yet. We are hoping to publish it, of course, after we get more samples on more patients to show the real correlation between factor levels on a PK style study. So then finally, before I close up this, can clot chip be useful with non-factor therapies? Now, obviously the non-factor therapy that is currently, there are two of them that are currently in trials. One of them is fitusiran, which is a antithrombin siRNA, as you know, to decrease your antithrombin levels. This data is not on patients on antithrombin, on fitusiran. This is taking patients' blood and adding antithrombin antibody to the blood to decrease the level so that it can simulate the same antithrombin inhibition that is seen with fitusiran. So that's what this is. These are depletion experiments. We used sheep human antithrombin antibody, and we had a particular method of targeting a level of 20% or so antithrombin. That's what the drug does too. And we used a short-acting, short half-life recombinant factor 8 to add to it, because we wanted to see what happens when you add factor 8 to the antithrombin depleted blood. We target a level of about 50% factor, not full correction. And then for the antithrombin antibody and factor 8 combination, we incubated the antibody first, and then we waited for some time, 30 minutes, and then we added short-acting factor 8 15 minutes before recalcification, so that we can then measure the assay. And then everything was performed in duplicate as we should, all experiments. So let me walk you through this. So this is not hemophilia patient. This is normal, the first one. So this is clot chip antithrombin depletion in normal patients. So normal baseline is the blue curve, right? Now, remember, in hemophilia, the curve shifts to the right. It prolongs. When you add antithrombin antibody, you decrease the antithrombin level, it should go to the left, right? Because you're making it more prothrombotic. And that's what it does. So TP goes from blue to red to the left. Now, these are normal patients, so it goes only slightly because there's already a normalization of TP, so it goes slightly lower. Again, we did not expect this. We were pleasantly surprised to see that, yes, it can still go down, and it's sensitive to that. So shortens the TP, shifting the curve to the left. What about hemophilia? So again, by now you know what the curve looks like. So baseline is the blue curve. After you add factor 8 to it, that's the black one. It decreases the TP, right? Brings it to the normal range. That's the black. But if you only put antithrombin antibody, it still decreases it, but not to the normal range yet. It decreases, so it goes down in hemophilia patients very nicely to the normal range. However, not as much as factor 8 did. What if you added both? Look at that. It went further to the left. So blue, red, black, and then green. Even further to the left by adding factor 8 in 50% range. So we were able to show that not only it decreases the TP by adding antithrombin antibody, if you add factor 8 to it, it further decreases the TP. And we had 2 patient blood samples kind of showed the same exact thing, that it shortens the TP close to the normal range. In addition of factor 8, further shortens the TP. And these are the numbers that TP that I was talking about. So this was the first patient that I showed you on the left-hand side. That was the baseline. There are 2 different values in the same patient. And then factor 8 decreases to 390 seconds. Antithrombin only decreases to 480 seconds, so not as much as factor 8, but it still decreased it from 990 to 480. And if you add both of them together, look at that, 270. So it decreases really, really well after you add factor 8. Now, this is crucial information because we want to know how much factor 8 to give to patients who are on something like fitusiran, for example, and this could be useful for that measurement at some time point. So this was our data in patients in hemophilia blood with antithrombin depletion. So this part of the talk, to summarize, clot chip has potential to be used as a point of care PK device in patients with hemophilia, right? I showed you that. But we still need to do more studies. It's only a few patients. We need more to target factor levels in active patients. So we want to take active patients, we want to target certain factor levels, and we want to see whether we're able to maintain that with the clot chip PK, giving the power in the patients in the hands of the patient. That's what the real study would look like. And then I also showed you that it has potential for monitoring non-factor therapies, such as the antithrombin siRNA that is currently in trials. But we do need data in patients who are actually on fitusiran. It will come as the drug gets approved, hopefully soon. So that's the summary of the second part. And we're not done yet, obviously, from our research point of view. We have a lot more planned. We recently got funded for an entirely different effort from the Department of Defense here in the United States. And we are developing what is the next generation of the clot chip assay. It has 4 channels, 4 microfluidic channels, and we're lining it with different agents to pick up different parts of the coagulation cascade. So these are all still each of them will take a drop of blood, but So instead of 1 drop, 4 drops of blood, but each of them will be lined with different things so that we can pick up different parts of the coagulation. Now, the inspiration here was trauma patients. So trauma-induced coagulopathy, or TIC, is a very complex problem, and you can have problems in any part of the coagulation cascade. And the first hour and a half is very crucial to save patients' life with trauma, because you need to know what to give them: plasma, red blood cells, platelet. And so this is a inexpensive, portable, handheld method to put the control on the battlefield in the soldier's hands, so that they can measure and give corrective measures, or in the ambulance, or in the helicopter, or even in the ICU for that matter. For example, with ECMO patients, same thing can be done. So that's our next sort of project. By the time we are doing the completing hemophilia work, we already progressed to the next level of this. So we are very excited about this, and as I said, we just got funded for this effort. Now, I want to obviously acknowledge a lot of people who made all of this happen. My clinical colleagues that are listed here, the engineering folks that actually invented some of this technology, the first two here, Pedram and Mike, and then Anirban and Omar that I work with. I have the privilege of all the graduate students. We have a lot of funding that goes into supporting this. And my whole HTC team, without whom obviously I will never be able to do anything of this sort. They all help in getting blood samples, consenting patients, transporting samples, and most importantly, all our patients. So without them, there is no research that you can do, right? We all know that. So I'm very, very thankful to our patients as well. So that's all I have, and thank you for listening to this talk. And I'll be happy to take any questions.
Thank you very much, Dr. Sanjay. This is all the information. It's very interesting. There are some questions from the public, but I would like to understand before. Sorry, please. Let me ask.
Yeah.
The calcium is in the strips, in the calcium.
Yeah.
I don't know.
Yeah. Sorry, you broke up, but I think you were asking whether the calcium was in the strip. Yes. So calcium is pre-added to the strip, so you don't have to add it. You just put a drop of blood on it, and it does its job.
Okay.
Yep.
Okay. Thank you. This is a prototype. I understood that. This is not the final version of the point of care.
Correct.
Okay. Do you think there will be controls to the phase?
Yeah. So we are currently investigating that. So we're working with the FDA, obviously, to get some approvals. And we're currently trying to figure out whether each sample needs a control, or you can go by the control values that we have generated. So we don't have an answer to that yet. But we have also discovered that each patient is its own sort of, they start with a certain T peak and they go to a certain T peak. It is different between different hemophilia patients. And even though they are prolonged in a certain range, but each person is different, and it reflects their blood coagulation or coagulability. Everybody does not bleed the same way like anybody else. So. Okay.
Let me do one question more before to begin with another kind of questions from the public. Do you think it will be necessary to measure like a chromogenic state at the same time that at the beginning to use this point of care? I mean, to know exactly the factor VIII value that you are starting, I don't know, to make a, or we hope that in that point it will be very exactly the value that you were expecting in different kind of factor VIII value. I don't know if say it to me.
So we, I think to use this as point of care for each patient, you might have to know what their PK curve looks like. But once you establish that, then you don't have to keep repeating it because that's where their PK curve is, and we know where they live. So we are able to give this. That's the study we are planning to do the PK curve at the beginning of the study for each patient, and then give those parameters to those people and divide them into different zones, and then the activities based on that, and then maintain their prophylaxis to those zones, so that it is their PK, not anybody else's. So it's individualized in that sense. So that's a very good question. Yes.
Okay, thank you very much. I have another more, but please, Mara, can you continue?
Yes, I don't know if you can hear me because I have like a problem with the Wi-Fi, but there's some questions about the audience that probably you can help us, Doctor, and
Yeah.
ask something that I know that you explained something about, but what do you think about if we use the viscoelastic test like TEG or ROTEM with this monitorization about the hemophilia patients?
Yeah. So we are actually hoping that we can replace the viscoelastic assays and use clot chip instead, because it's easy to use. It's point of care. It's much easier. You don't need an operator. You don't need a lab to do the test. We are trying to get the control in the hands of the patient, not the hospital.
Yeah. Yeah,
good question. That's the vision.
Yeah, I understand that you can have this new model for the trauma patients, and maybe if you can change the strips to different factor levels, you can measure all the factor in the machine.
So
or the platelet.
So it's not able to differentiate between factor 8 or factor 9 deficiency, first of all, because it's measuring blood coagulation. It's not measuring the factor level, right? And it is measuring platelet function in the different part of the assay. So it is able to measure the delta epsilon max, which picks up the platelet function. But the platelet function could be defective because of a congenital problem. It could be defective because of a drug like SSRI. It could be aspirin. It will not be able to differentiate that. It will just tell you that the platelet function is abnormal.
Okay.
Mara, te perdimos un poco. We lost you a few seconds.
Evelyn, si quieres seguir con la siguiente pregunta.
Okay. Well, there is a question from the audience that asking from software, but I suppose, well, because this is a prototype, we cannot talk about different versions about software, or we can do at this point.
Not at this point. I think it's early enough that we have created the first version, and then now we are working on the second version with different channels. Will that be useful in patients with hemophilia? Yes, it will be, because one of the channels is a tissue factor line channel that we are doing. So we think actually the sensitivity might actually improve with the tissue factor channel. So if you remember, in ROTEM or TEG, that is tissue factor based, right, assay that is done. So it will be similar to that. So this is the first version of it. There will be more refinement of this for patient, and I think our sensitivity will actually get better over time. We are hopeful at least.
Yes, of course. Mara, ¿puedes hacer la pregunta de Mirta Arias que nos hace favor de una sobre el factor 9?
Yes, and we know that not in every for the measurement about the long-acting factors, we need and special in some cases a specific measurement reagent to measure the factor. Do you think it could be helpful? For all these
That's a very good question.
factors like factor 9 or factor 8?
Yeah, so this is agnostic of any reagent, right? We are not using any reagents here. So because it does not use any reagent, it does not depend on that. So you could have any factor, any extended half-life factor, and it would pick up the measurement of the blood coagulation irrespective of that. So the kinetics that we did, well, the extended half-life was on a factor that had, I'm not allowed to say which one because it's not published yet, but it could have had problem with the reagent, but our assay did not pick it up. We were able to correlate with the chromogenic assay very well. That's why we use chromogenic assays to compare so that we don't have any problem with the reagents or whatever. But we shouldn't have any problem with that because it's not measuring based on reagent. It's unmanipulated blood, whole blood assay.
Yeah, it's really, for me, when I saw the first time this lecture, it was really impressive because we know that probably this is the future of the measurement of the hemophilia patients, because as you said before, you can put like a drop like diabetes patients or any other point of care that you have in home, and this is for me incredible, but because probably in the future you put this drop and you saw this flag like red or green as you mentioned, and the patient knows if he need factor or just can go to the life. No,
right.
I really believe that this is a super idea, and the future of the measurement about the hemophilia patient, even the thrombosis patients, because as you mentioned, you can measure antithrombin 3. Probably in the future you can add some other tests, you know. And this, I think this is impressive. Evelyn, no sé si tienes otra pregunta.
Yes, I would like to ask.
Before she asks the question, let me just comment. So you talk about thrombosis, right? So you're right on the money for that, because watch out for a publication that is going to come out soon in COVID patients with clot chip. So we are able to show a difference because they have more thrombosis. So I didn't show you the data, but that is coming. Good question.
Very nice to know. Yes. So I think there is a little difference between to take the blood with different kind of type of. Is it right? I mean, with ¿cómo se dice, Mara? Con aguja, o me parece que hay un efecto por la aguja.
Yeah, Evelyn tries to say if you think that probably the pinch can give us some effect to the sample, because you mentioned that you put the drop from the syringe. But if probably the pinch in the future can give like any I don't know, effect, disturbance.
Good question. Evelyn is from the lab, so she knows this. So we have done studies from venous blood, from capillary blood, from the finger prick, and from a line. All of that we have done. So the correlation between venous blood and capillary blood is very close. So we are able to go back and forth, but it is designed for a finger prick for the patient. So that's what the future studies are all on, finger pricks, because that's capillary blood. But we have done the testing between venous blood and capillary blood. That's a good question. Yeah.
Okay.
She works in the lab. She knows. The QC,
yes, that's
right?
kind of questions that we have in the lab. And I know for these kind of patients, it's very important to have a different kind of test that make the life easier than it is now. But we are always interested about all this kind of viability of the test, the new test. So so that's what we do, that kind of questions. Thank you very much. I think, of course, there is a great potential, as you just said, not only in hemophilia. It's about thrombosis right now. Very interesting, and congratulations about this work. Is very, very interesting. I suppose it's very difficult to go in this way, a very long way. I mean, to compete with very big companies, and there is a lot of I need for money, I suppose, as you said. Congrats, very. I don't know how to say.
Thank you. No, I understand. Yeah.
We are very glad to have you here today. Thank you very much. Mara, ¿yo estoy bien? No sé.
Yeah, there's a question, but I don't know, probably you are going to share this information later, because from the audience ask if you say some effect from the lupus anticoagulant in the clot shape, but I don't know if you can share this with us.
No, I cannot right now.
Okay.
Sorry.
Yeah. Yeah, I understand, because you shared that you probably public this information, but we are going to be super warning about this information, because I think is this new all potential that the clot sheet has. I think it's amazing. Well,
Thank you,
Professor Ahuja, I think this is one of the most exciting lectures that we had this month.
Thank you.
Because we know all this new future about the hemophilia patients. We have already a different kind of drugs. The treatment right now for the people with hemophilia, it's really exciting. We are living like new data, and now with this new technology, I think it's probably in the future, even in the gene therapy, you are going to see your level, and you don't see anymore. But I think this is a tremendous option, and I really want to thank that you can be shared and can join us this afternoon. Doctor, I really want to give you our recognize, and thank you so much. Para nuestros asistentes, el doctor Ahuja va a estar en nuestro congreso anual en junio, no pueden perdérselo. Los invitamos a todos que estén con nosotros en junio en Monterrey. We're invited everyone to join us in Monterrey, because you are going to be there with us and sharing some data about this. Thank you so much, Evelyn. ¿Algo
Mara,
que quieras agregar?
No me quiero ir sin recordar a nuestros asistentes que a partir de hoy se abren las pláticas que están incluidas en nuestro tercer taller de enfermedades hemorrágicas. aparte de que van a tener las 4 pláticas que se han impartido todos los lunes como sesiones plenarias, van a poder disponer de ellas on demand. Y por supuesto, 17 pláticas cortas, todas referentes a hemofilia, laboratorio, cuestiones clínicas. Y por supuesto, la sesión del viernes, que está muy interesante. Tenemos 2 ponentes diferentes e incluye la sesión en vivo del sábado, que vamos a estar hablando de enfermedad de von Willebrand. Entonces, que no dejen de inscribirse. Creo yo que va a estar muy interesante y van a poder compartir con nosotros todas sus dudas el día sábado en vivo. Y bueno, nos va a dar mucho gusto tenerlos ahí. Por supuesto, agradecer al doctor Sanjay. Thank you very much. Again,
Gracias.
thanks for being here and for go with us on June. We will be very happy to have you there. Thank you very much.
Thank you. Good night, everybody.
Yeah. Thanks, Dr. Ahuja. See you soon.
Bye-bye. Yeah. Bye-bye.
Bye. Adiós.
Adiós a
Gracias
todos.